Hi everyone, thanks for joining. So we have Charles Buchanan. He's a fourth year dental student at UNLV School of Dental Medicine and District 10 trustee. As a member of the governance committee, Charles reviews the ASDA governance documents and proposes changes to keep documents current. Currently serving as the ASDA National Licensure Task Force, he helps develop strategies to address licensure concerns in states that haven't made changes. As a side note, Charles also has his own district conference today, but he woke up early West Coast time just to speak with us. So, an extra thank you for joining us today.
Thank you. Thank you. No problem. District 2, how's it going? So excited to be here with you all this morning. So today we'll be discussing a little bit about barriers to care and diversity in oral health care, mainly what it takes to treat diverse populations at the student level. All right, so let's just start off with barriers to care. We've all been introduced to this at some point in our ASA careers, I hope already. So there's an extraordinary diversity among people who seek oral health care, but because diversity among us health professionals still doesn't reflect the diversity in the population overall, people are likely to see caregivers with experiences that are slightly different than their own. And because of this, one of two things can result, right? So, number one, you can grow as a provider and get a deeper understanding of your patient. Or number two, there can be a great misunderstanding, AKA a barrier to care. And so, a barrier to care is pretty much anything that can prevent people from receiving adequate health care. And today we're going to discuss some ways in which we'll end up closer to the first outcome. And in the chat, just go ahead and list groups of people who might be experiencing higher rates of barriers to care that you already see at your dental schools. So some examples that I have are non-English speaking families. Great, Michelle. I have some socially disadvantaged groups such as like rural and urban poor with hard access to transportation, correct. Many ethnic minorities, institutionalized elderly, low income families, sure, and members of the LGBT community. All of these are great. So these are the groups of people who are consistently at risk for being unable to access the necessary dental services that they need. And so I'd be remiss if I didn't include in my presentation something about intersectionality. And I hope some of you might be familiar with this term. So the intersectionality theory is that no one is simply a man or a woman or gay or straight and so on. So we can't be reduced down to one characteristic. Instead, multiple parts of our identity intersect with each other, and this influences the way we experience the world and how we move in it. So, for example, I don't experience life just as a man, right? I'm a 26-year-old, able-bodied, African-American man from Las Vegas, Nevada, pursuing an advanced degree. So all these different parts of my personality and my identity kind of frame the way I see the world and how I experience life. So education, let's talk about socioeconomic status for a little bit. Education is probably one of the biggest predictors of health. It's been said that actually adults with less than a high school education experience untreated tooth decay nearly 3 times that of adults with at least some college education. And then in addition to that, adults with less than a high school education experience more destructive periodontal or gum disease at the same rate, nearly 3 times that of adults with at least some college education. And so the real reason education is a big predictor of health is not the education level itself, but because less educated people experience poor living conditions, financial strain, stress, etc. These factors all come together, and we'll see patients suffering with depression, or attention deficit or hyperactivity disorder, obesity, smoking, poor oral health. This is partly because they have limited financial resources and partly because they tend to be dissatisfied with the care that they receive, so they avoid it. But let's take a look at ourselves as student doctors as well. So, for the most part, we might consider patients to be proactive or interested in their health when they're asking us a lot of questions, or they're engaged in conversation. However, we must remember that patients of a low SES are typically less assertive than other patients. So they ask fewer questions and reveal less about their health concerns. So why do you think this might be? I also want to see some activity in the chat with this one. Why do you think that a person of like a lower SES might not be as assertive in their care or engaging during their appointment? Used to being shot down. Yeah. Previous distrust, scared of authority. Awesome. Overwhelmed with different terminology. All of these are spot on. All of these are spot on. Yeah. So they aren't knowledgeable, right? Poor healthcare literacy. They're not knowledgeable about their health issues. They might be intimidated by health professionals. It could be considered disrespect to challenge you, all these things. And so, we all have an implicit bias, and we'll talk a little bit more about that term. But most people are aware of their own biases, but not everyone is aware of the more like covert ones. Implicit bias refers to the attitudes or stereotypes that affect our understanding, our actions, and our decisions in an unconscious manner. And so because of patients with a low SES, they typically rely on television or people they know for health information, and they use that to fill that knowledge gap. Just a few years ago, there was a documentary on Netflix called Root Cause, and it had these bogus claims about what a root canal might lead to in terms of your systemic health. And it was kind of bogus, debunked science, right? But someone might read or watch that and take that as truth, right? And then may not come to the dentist, may ignore that root canal that they need or anything else, right? I've had patients who need several extractions, bone grafting, an upper and lower denture, and there's no way to pay for it for that patient. How do we treatment plan? And what about the patient that lacks transportation or their work schedule isn't flexible? So these are things that we should be mindful of with our patients. Okay, so what's implicit bias? Basically, it's a term that describes what's happening when, despite our best intentions, without our awareness, racial stereotypes and assumptions, they creep into our minds and affect our actions.
Implicit bias.
Implicit bias.
Implicit bias.
2016 was the year that implicit bias went somewhat mainstream.
Yeah, so when Hillary Clinton mentioned implicit bias in the debates, our phones started blowing up, all our friends started emailing us about it.
But what is implicit bias? Implicit biases are basically thought processes that happen without you even knowing it. Little mental shortcuts that hold judgments you might not agree with. And sometimes those shortcuts are based on race. First, some clarity. Saying someone has an implicit bias is different from calling someone a racist.
The word racist is a highly loaded term, right, here in American society. A lot of times, when people are using it, they're thinking of the kind of old-fashioned Ku Klux Klan style racist.
But implicit bias isn't anywhere near that, explicit.
Implicit bias is something that comes out of ordinary mental functioning, out of how the mind normally works.
We've all grown up in a culture with media images, news images, conversations we heard at home, our education. Think of that as a fog we've been breathing our whole life. We'd never even realized it, what we were taking in.
And that fog causes associations that lead to biases.
I somehow know that if you say peanut butter, I'm going to say jelly. That's an association that's been ingrained in me because throughout my life, peanut butter and jelly are together. And in many forms of media, there's an over-representation of Black men and violent crime being paired together.
And because of that, I actually deep down inside have been taught that Black men are violent and aggressive and not to be trusted, that they're criminals, that they're thugs.
With all those associations, I'm not trying to let us off the hook, but in some ways, none of us stood a chance.
Starting today, we'll post a video a day dealing with one challenge of understanding implicit bias and its relationship to race and exploring ways we might combat the problem. One more thing, if you're seeing this and thinking that it doesn't apply to you, well, you might be falling prey to the blind spot bias. That's the scientific name for a mental bias that allows you to see biases in others but not in yourself. We're biased.
Charles, you're muted.
Thank you. Let's talk about the health literacy for a bit. So the traditional idea of literacy is the ability to read. But to be health literate, we have to kind of include some other things in that. So you need to be able to understand the language in which information is presented, have to have the access to reliable and relevant information, have the social skills to discuss your health matters with others, have adequate hearing and/or vision to get the information, and understand how to apply that information. So that's a lot to ask of someone, even some of ourselves, right? You're thinking like, oh, I don't know if I can even communicate my own health matters to someone else, right? And dental jargon is so confusing, right? And like you're in the middle of it, like some of you may be first years on here, you're learning mesial, distal, mandibular, apical, right? Like all these weird, confusing words. And how do you think our patients feel? I think we fall as dental students, we tend to explain dental related information the same way we learned it. We don't really break that down very well for patients. So, how do you think they feel when you're like, oh, I'm going to percuss your tooth? They're like, what? Or you're like, I've noticed rampant cervical decay here, right? So just be mindful of these things. So here are some of my tips, my communication skill builders for you all. Here we go. So number one, watch your language. Words such as palpate or caries or anything like that, that can frighten and confuse rather than inform. So instead, use terms that your patient can understand. Like for example, lingual, you can say the part of the tooth closest to your tongue. I like to use analogies all the time with my patients. If I see a fractured tooth that needs a crown, I'll go, have you ever had a cracked windshield? When you get one, you want to replace it quickly because you don't know if that crack is going to get bigger, if it's going to spread. And when it does, it's too late, right? And so I can say like, well, Ms. Williams, your tooth has a crack just like that windshield, and I'm concerned it may get worse. So you're breaking it down in a way that patients can understand. Use multiple formats, so combination of words, diagrams, and videos. This helps appeal to people with a diverse learning style and literacy resources. So I'll pull up Colgate education videos in my op and show my patient if there's something they're not understanding, as well as I think Oral-B puts out a very good booklet. Especially when it comes to dentures, I'm always showing pictures and videos. Number three, let's create shame-free environments. We want to make it easy for patients who don't understand information to get the assistance that they need without feeling embarrassed. So for example, I routinely offer to help patients fill out their intake paperwork during their comprehensive exam. And to make that a little bit more comfortable for them, I say, I know these forms may be confusing. I will help you if you like. So by saying this, you're acknowledging that your patient may not be alone in their experience, but you're also acknowledging that there are some concepts that they never thought about before, but you're also respecting their right to seek help with the forms or not. You're giving them that autonomy in terms of, wanting your assistance or asking for it. And so you also want to use metaphors and pictures to help explain complex ideas. They might be something we consider familiar, might be foreign to someone else. So in the chat, does anyone have like a metaphor that they use or they've heard doctors use? Or if you all have been like previous assistants or hygienists, is there anything that you like, for example, when I'm talking about why we need to do perio first before we do any restorations or anything like that, you talk about it's the foundation. It's kind of like you're building a house. And if you don't have your foundation right, if you don't have that settled, everything you build on top of that is just going to fail. And so that's something I use when, I wouldn't say it's pushback, but a little bit of a concern for a patient when they really just want to fix that tooth, but we don't have any of their perio issues resolved. Just tell them the angle towards the bristles. I like that. Very good. And then while we're typing in the chat, these are some words that could be used as an alternative. So pulp, if there's like an endo problem, you can say the nerve of your tooth or the blood supply of your tooth. For pathology, benign, it's not cancer, it will not cause harm. Caries, tooth decay, or you can just say cavity, right? Everyone kind of knows where the cavity is. Decay still might be a little bit too advanced for some people. Radiographs, x-rays, lesion, wound, sore, oral mouth, right? And proximal, in between your teeth. I already talked about lingual, like the side that's closest to your tongue. So these are words that your patients can understand a little bit better. Increasing your knowledge about health literacy. So these are just some examples, some good resources that you can use. Okay. Now let's talk about the genderbread person. This is probably one of my favorite representations of these concepts. We're going to be talking about gender and sexual identity for a bit. So gender identity, gender expression, biological sex, sexual orientation, they all exist independent of each other, actually. So we're going to go by these one by one and kind of break it down. So gender identity, it's all about how you think about yourself, how you internally interpret your body chemistry. You can feel more comfortable associating with societal norms of a woman or a man, or neither. And you can certainly have elements of both. So it's been accepted that we form our gender identities around the age of 3 years old. And then after that age, it's incredibly hard to change them. So once again, gender identity is how you interpret your body chemistry. Gender expression, that's how you demonstrate gender through the way you act, the way you dress, behave, interact with others. This could be intentional or unintentional. There's a lot of room for flexibility here. And this is pretty much interpreted by your traditional gender norms. Men wear pants or women wear dresses. Women like the color pink, things like that. Your typical what we kind of see in television and film of how a man or a woman is supposed to behave, right, or be. But this can change from day to day, from moment to moment, outfit to outfit, just events. This is very fluid. Biological sex. So that's pretty set. That's what's under the hood, is what I like to say. This is objectively measurable by organs, by hormones, by chromosomes, right? So this is your females and your males. And we know what that entails in terms of anatomy. But this can be more nuanced than that, of course. Intersex people exist. This isn't binary as well. This isn't male or female. There's variations in between as well. And then attraction, that's sexual orientation. That's who you are physically, spiritually, emotionally attracted to. And so I like to use the genderbread person when I'm explaining these concepts, just to show how they're independent of each other, but they can also interact with each other. And these are all how you form your gender and sexual identity. So I promise you, no matter where you practice, no matter what type of patients you see, no matter what city, geographic location you're in, this will be of importance to you. So let's go over some communication skill builders really quick. Okay. So with these concepts, the best thing to do, in my opinion, is to practice out loud. So people who rehearse these conversations about sex and gender with friends and colleagues, they may feel more comfortable conversing about these topics with their patients. And if you're more comfortable, then your patients will be. Number 2, don't ignore it. Research suggests that most LGBTQ people, they would like their health professionals to know about their identity. You want to avoid judgment. So even subtle signs of disapproval can discourage patients from sharing their info that's relevant to their health. And then number 4, as students, this isn't something that we directly have control over, although I do know students who have advocated for this at their schools, and some schools are now transitioning this as well. But change your paperwork. This is something to be mindful of when you start practicing and you have more control over your career. But include an option for patients to indicate sexual identity on their health their profile questionnaires. There are options. I don't know if you use Axiom at your schools, but any type of, dental electronic health record, most of them have the ability to kind of adjust that, and you can put in different options besides man, woman, male, female. And number 5, relax. This is a lot of information. It can be confusing, even for those who are part of the communities and allies as well. So let's talk about what happens if you mess up. So maybe you misgender your patient. Maybe you misgender someone you're meeting for the first time. It happens, right? In misgender, that means to refer to someone as a different gender than the one they are. What you should do if that happens, take a deep breath, apologize, make it short, correct yourself, and continue. Don't dwell on it. You don't want to make the situation worse. You should also be sure to keep the focus on the person that you've misgendered. You want to avoid dramatic expressions of your guilt. You don't want to oh, I'm so sorry. I'm working on this. I'm an ally. Because then you're taking the attention off yourself. You're probably making a way more dramatic situation. You're bringing more attention to the situation than it requires. So just a short, simple apology. So just correct yourself. So for example, if you have a transgender patient and you misgender them to your faculty when you're doing your start check, it's very easy to just say, no, I'm sorry, correct yourself, move on with the presentation, right? And then we'll have a Q&A after this if you have any questions about that. So why it matters. These are all the reasons why it matters. Bisexual and homosexual individuals reported a substantially higher proportion of fair or poor oral health compared to heterosexual individuals. There are some surveys that have gone out about discrimination and maltreatment. A survey of people in Cleveland found that only 10% of transgender people report visiting the dentist regularly. So these are just some reasons why this is important. Like I mentioned, no matter where you practice, no matter what type of patients you see, this is something that you're going to encounter. So, and this is just how the ADA code applies. If you're at least, I would say like a second or third year when you're studying for boards or something like that, you should be familiar with these terms. So these are basically the 5 principles that the ADA kind of governs our profession by. So autonomy means to give your patient kind of the ability to determine their own treatment plan and make decisions for themselves. So when it comes to autonomy, one should use a patient's preferred name and their appropriate pronouns. And I actually don't really like using that term preferred either, because it's who they are. It's not a preference, right? And then we can go down the other ones too, but for sake of time, I kind of want to move on to some other important topics too, so we have time for Q&A. Race and ethnicity. So as we mentioned, people of a non-dominant race and ethnicity, they're often at a disadvantage where oral health and longevity are concerned, regardless of how much income they have, education they have, and other factors. And this research shows that the link doesn't have any genetic basis to it at all, but rather a social one. So there are several reasons why people of different races receive different dental care and respond to it differently. Let's kind of take a look at some of those reasons. Okay, so distrust. So some patients just steer clear of healthcare because of historical patterns of discrimination. I think we've even seen that with the COVID-19 vaccine. So do yourself a favor and you can Google the Tuskegee syphilis study, and it's still one of the most cited reasons among African Americans who are distrustful of medical treatment. So patients from racial and ethnic minority backgrounds are still more likely than others to feel their doctor fails to listen, to show respect, and explain things clearly. So let's talk about how this might show up. So your patient may never fill that prevalent prescription or decline proposed treatment if they distrust you. So I think it's really important to build rapport with your patients immediately. To me, my appointment, if I'm seeing a patient for the first time, the appointment starts when I receive them in the lobby, in the waiting room. So from that moment, I'm working on building my rapport with the patient, because I have about depending how fast you walk, 1 to 2 minutes with that patient before I even set them in the chair. So I'm getting to know them as a person. One of my favorite things to do is just to ask them, what do you have going on for the day? What do you have planned? Or if it's a Monday, how was your weekend? Simple stuff like that. But that allows me to it's a conversation builder to get a sense of something else I can apply, right? So if they're going to say, I'm just going to go babysit my brother or sister, or, pick my kids up from school, invite you to ask more questions about, oh, how old are your kids? You can get to know more about their family. It's showing get interest in them as a person rather than just, oh, I'm gonna, sit this person in my chair and, just tell them all the problems they need and then ask for money. Because a lot of times that might be the mindset that your patient is in when they walk into your operatory, right? So high risk, low knowledge. We know that research shows that daily stress of social discrimination, it contributes to hypertension, all other types of health concerns, right? But despite being at high risk, patients of minority backgrounds may be unaware of their health issues because they don't trust mainstream media, or they don't know much about their counterparts, limited access. But thanks to the Affordable Healthcare Act, a lot of Americans now have health insurance. It's gone up, and that's a good thing for us as well. Patient caregiver communication. So although patients and health professionals can establish trust even if they come from different backgrounds, rapport often seems easiest when people have a good deal in common. So right now, we'll go ahead and watch a video on that.
So bias by itself is an algorithm of the mind. So it's a complex set of emotions that have become attached to one another that then manifest into the way we perceive, reason, remember certain things, certain incidents, and make decisions. And that's what bias is. Now, there's two forms of, big picture, two forms of bias. One is conscious bias or explicit bias, something we know as, racism or sexism or anti-Semitism or even transphobia, Islamophobia. These are forms of bias where people hold conscious, explicit beliefs about other groups, whatever that group may be, whether it's women or people of a certain gender identity or sexual orientation or ethnic group. But then there's a form of bias called unconscious bias or implicit bias. And what unconscious bias is basically ingrained habits of thought that lead to errors in how we perceive, reason, remember, and make decisions. And over the last 20 to 30 years, leading research from across disciplines, from criminology to health policy to marketing and advertising research, has really shown that unconscious bias is one of the leading causes of inequity in our country. First of all, knowing one's bias is really important. So for the vast majority of Americans, we won't say that we're biased, because we're not, actually. Consciously speaking, we believe in the three pillars of our democracy: life, liberty, and the pursuit of happiness for all people, regardless of our color, regardless of our gender, our sexual orientation, our religious beliefs, because those are deeply ingrained values we hold. But when I talk about bias, it's really about unconscious bias or implicit bias. And that's, again, not our fault that we have it, but in the age we're living in, we have all the tools to hack it, to break that bias. So it is something that we have to be responsible for. So the first thing that health practitioners, providers can do is know their implicit bias. So log on to Project Implicit and take a free test that takes 2 minutes to do, but really see where on the spectrum do you fall with respect to racial bias or gender bias or sexual orientation bias or age bias. So we become aware of, wow, this is how my brain is primed to see people. And this is how I'm making split-second decisions. That's the first thing, right? The second thing is really looking around our friends and family circles. Unfortunately, we're still living in an economy where less than 9% of our physicians and less than 15% of our physicians and our nurses and nurse practitioners are of color. And when I say of color, really primarily African American, Latino, and Native American. So these are really small percentages. For a country that's over a third African American, under 10% of those practitioners that are providing to those communities, that may come from those communities, may understand the experiences of those communities, are not from those communities. This doesn't mean that we can't provide equitable care to those communities. Of course we can. We have that potential. But we need to hack bias to do that. And one of the primary ways of hacking bias is social contact. So look around and do one thing. Notice who are our intimate friends? What's their background? What ethnic background do they come from? What's their histories? And just literally do that self-reflection. You can even write it down, map it out, so you know in your own inventory that, oh my gosh, most of my friends are Black. Most of my friends are white. Most of my friends are Indian or Asian or Muslim, whatever they may be, whatever the identity is. They're gay or straight. Because that way you know that that's the community you're living in. And that's the community you're relying on to carry on. So taking that inventory check.
Okay, so that was a good video that explains just kind of some of the topics that I was talking about earlier and gives a good summary. And so there's two more things that I really want to touch on before we get to our Q&A, and that's number one, language differences. So it is incredibly hard to offer quality care across a language gap. And here in Las Vegas, we have a large Spanish-speaking population, and it's estimated that language differences increase a patient's risk factor by 25%. And the reasons are that it's difficult to make an accurate diagnosis if the doctor can't fully understand what the patient is experiencing. And even if your diagnosis is accurate, it's difficult to ensure the patient is fully informed in their options. I actually saw this firsthand, I would say about a month ago, with one of my classmates who had a Spanish-speaking patient that came for the comp exam and the initial exam, and her son acted as the translator for the treatment that was supposed to be done and the findings and everything like that. It turned out the patient was due for a full mouth extraction. That was what was planned, and the patient had no idea. So the patient came for the extraction appointment actually and was like horrified because she didn't realize she was about to lose her teeth that day, right? So I think it's best practice to work with a professional interpreter in clinical settings. You can use a classmate or assistant who speaks that person's native language, but definitely my number one piece of advice is to avoid patient's family or friends as the interpreter. You know, this number one ensures confidentiality. It prevents a conflict of interest and makes sure that dental terms are communicated clearly. Number two, address the patient directly. I can't stress this one enough. Face your patient, look your patient in the eyes when you're talking to them, no matter what language they speak. You don't want to look at the translator or the interpreter when you're discussing treatment with a patient. Also, don't shout, don't speak like overly slowly or too quickly. You want to speak in a normal tone, in a normal pace. Okay. Disabilities. So I really want to talk about people first language. So patients with disabilities, they're confronted with a very frustrating situation, and people tend to treat their disability as the most important thing about them. So I practice people first language all the time. And if this is your first introduction to this kind of theory, this idea, I hope that you take this away with you today. So people first language, it's basically addressing a person first, and then whatever disability they have, you address that second. So like it emphasizes the person first, not the disability. So if you have a patient with autism, you don't want to say I have an autistic patient. That doesn't define them. Their disability doesn't define them. Or even homeless people, a patient experiencing homelessness, or a person experiencing homelessness, a patient with HIV. So you're acknowledging that that person is human, right? So please take that with you after today, people first language. These are some communication skill builders. talk to people with disabilities directly, identify yourself for sight impaired persons, treat persons with adults with disabilities as adults. And then these are some examples that I provided for you, right? So a person who is deaf, that's the people first language. You don't want to say a deaf person, a blind person, a person who is blind, visually impaired, the disabled, a person with a disability. So you're always putting the person first, or you can change this in for patient instead of person. And age. So we do deal with a variation, the spectrum. We deal with young patients, we deal with older patients. This is just something to keep in mind as experts predict that 1 in 5 Americans will be 65 or older by the year 2050. And so when we talk about ageism, it's a discrimination based on a person's age, and it results largely from negative stereotypes of older patients or older adults. Some of the signs that we associate with aging is, the process of decline. We believe that as you get older, hearing loss, vocal changes, cognitive defects, all these things, but we have to keep in mind that everyone's different, right? In terms of when you're interacting with children, you always want to let them set the tone. Acknowledge the parents' role in childcare, and parents have valuable information about their children's condition and can comfort them better than we can. But however, it's very difficult to treat our pediatric patients and manage parent emotions as well. So for me, when I treat pediatric patients, my mom is in the lobby or not in the op, things like that. And then we'll wrap this up with what's ASDA doing. So I think it's really important for you to know that we have 2 policies dedicated specifically to barriers to care. That's our H1 and H2 policy. So H1 talks about student involvement to address barriers to care, and H2 is evidence-based solutions for barriers to care. And not in this presentation, but I'm sure that you've all talked about mid-level providers in your districts or at other events, as well as some of the things that ASDA is doing. We do have our ASDA action alert system, and some of those policies that we're advocating for deal with barriers to care too. So this is just a nice summary slide that I like to show you. Every year, traditionally, we do go to Capitol Hill and we lobby Congress. We had a virtual lobby day this year, and hopefully next year we'll resume that. And then these are some of the resources that I used for my presentation today. All right.
Thank you so much, Charles. My notes are so long right now. I especially loved your advice for building rapport when you take them in from the lobby, because it's always that kind of awkward conversation.
Of course.
How are you? Is it cold outside? And I like some of those tips that you gave. So just like last time, if you have any questions, since this is a smaller group, you can put your name in the chat and unmute yourself. I got a few that were privately messaged to me, so I can read those out as well. But I wanted to start actually with one of my questions. So I know we talked a lot about making sure that treatment plans are fully understood, especially for there's a language barrier, lower social economic status, and they're not as assertive asking questions. I know we took a class and the social workers were speaking to us and they were saying to make sure treatment plans are understood, you should ask the patient to repeat it back to you. And I kind of felt like that was a little awkward and demeaning. Like, oh, did you understand what I said? Can you tell me now? And so do you have any tips or advice for how you would approach something like that?
Yeah, so that's a great question. And I think that's something that everyone kind of struggles with, right? Like you don't want to offend your patient or, make them feel like, oh, do you get what I'm saying, right? So I always put it on myself. I always say, what I'm hearing is this. And that kind of sets the ground for your patient, if you're misinterpreting it wrong, for them to then correct you. So like, no, this is actually what I think is going to happen. So shift it to yourself. So instead of, do you understand this? Excuse me, say, this is how I understand it, right? And if there are any gaps, your patient can then step in if they feel comfortable, of course, but that works for me.
Thank you for that. That's very helpful. Another question I received is, to what level do you recommend clinicians receive training to more effectively provide care? For example, how much Spanish should we learn? How much sign language should we learn? Something like that.
Yeah, I think it's always a great idea to just have a basic understanding of, I would say, just like greetings to start with, or just different maybe directions like turn to your right or turn to your left, or you can do that in any language. I think that is a good foundation. I think that just sets the tone that lets your patient know that you are like an ally, right? Or you're trying to understand their experience. I wouldn't, in my opinion, also disclaimer, I'm not an expert in any of these topics. I just have a passion for it. I would say your patient would appreciate that. And then in my opinion, it's not necessary to learn, half the language to communicate with your patient. That's where your translators and your interpreters come in.
Thank you. Another question I received was, what other types of analogies do you like to use when explaining dental treatments?
Yeah, so I talked about the perio one. I talked about the cracked windshield. Some other analogies that I'll use. I think when it comes to, in terms of how patients perceive the price of dentistry, we always get a lot of pushback on, wow, it's that expensive. To kind of alleviate some of those concerns, I let them know if finances are a concern for you, this problem that we have right now, it's going to be the cheapest it ever will be. So even if it is expensive, let them know that it could get more expensive if they acknowledge that finances are a concern. And also just kind of, let me think of another analogy I use. There's so many. I guess like, when talking about a cavity, the easiest one to say is just like a hole in your tooth. They kind of understand that more than just like decay or anything like that. You have a hole in your tooth that we need to fix. And so if you give me a little bit more time, I can think of some other ones I use.
Sorry for putting you on the spot there.
That's totally okay.
When you asked us too, I was like, I know I use them, but I
exactly. I'm
think
like,
about
oh, what are you? Because you're in the moment and it kind of just comes to you.
Right. So for the last question that we'll take, because we're just at about time, Evan writes, do you find it more difficult to maintain engagement and understanding with teletranslation as opposed to having an actual real life interpreter?
I personally do. I try to avoid the teleinterpretation as much as I can. I think there's just something lost, and it kind of just speaks to the virtual world, right? We're kind of experiencing that right now. There's something lost without that in-person, that feel. There's a lot of communication isn't just your words. It's body language, it's facial expression. There's a lot of other cues that we use to communicate. So for me, yeah, it is difficult, but if it's your only resource, some ways you can mitigate that is to, like I said, those other things, speak directly to your patient. And I think that's the biggest one. I think we get lost when we use interpreters because we're just so used to looking at the person that we want to get information from that we kind of ignore the patient. So even if you are using teleinterpretation, just please be mindful and respect your patient and communicate clearly and directly with them and not, just the phone.
Thank you so much once again, Charles. And
Thank you.
Charles is having his own district meeting in just a few hours. So really MVP of the day for this. So
thanks
thank
everyone
you
for having me.
All of the helpful tips. I know I learned a lot. So wanted to thank you.
Enjoy the rest of your day, everyone. Thanks for having me.
Bye.